The last speaker for today is Dr. Nikhil Balakrishnan. He's a cataract and a refractive surgeon practicing at Saideep Eye Clinic, Mumbai. Over to you.
Good morning, everyone. My topic for the day is what went wrong in refractive surgery, communication errors. So we know refractive surgery today has become a cosmetic surgery where patients have become extremely demanding. And with cutthroat competitions in today's times and refractive surgeon, multiple refractive surgeons in one lane itself, there's intense cutthroat competition. Doctors end up over-promising the patients just so that they can get the case. So the golden rule is always under-promise and over-deliver. Never ever promise a zero refraction. Counsel patients regarding spectacle independence, but never promise their refraction post-op will be zero. Never promise that crystal clear vision would be there immediately post-surgery or the following day. Tell the patients that there may be cases where the vision clears up over a period of time once post-op drops are used. Tell patients regarding the quality of vision, especially in high myopes. In high myopes where you're flattening of the central cornea a lot, the patients may have impaired visual quality, so this should be conveyed to the patient pre-operative. Patients undergoing refractive surgeries in their late 30s should be clearly counseled that this procedure is only to correct their distant vision and they would have to wear presbyopic correction once it sets in post-40. Always tell the patient the side effects of the procedure beforehand itself. The dryness is very common post-refractive procedures, especially when there is a cut of the anterior corneal nerves, and the use of lubricant drops may help to alleviate the symptoms. One may suffer from glares and halos, but it usually settles in times with most patients. If in case there is a regression post-op, if you rule out that it's not a pseudo-regression and the regression is true, it can always be corrected. Ectasia is one of the most dreaded complications of refractive surgery, but that is why we do a detailed preoperative evaluation to help avert this complication from occurring. So the idea of stating the adverse effects is never to scare off the patients, but to educate them to prevent post-operative scares. So I'll just run through a few special scenarios here. In cases of PRK, always tell the patient that there may be a chance of haze following the PRK. There would be no wow effect. You're not going to have that great 6/6 clear vision on day one itself. It takes time for it to clear. And there would be a need of placing a special contact lens in the eye for at least 3 days post the procedure. In cases of pre-presbyopes, especially high myopes, may find it difficult to adjust to reading close post-LASIK, especially those who have had a habit of removing their glasses to read before the procedure. In individuals post-40, regression is very common due to the change in the alteration of the corneal curvature, and they will need presbyopic correction at all times, unlike before, where they could simply just take off their glasses and read prior to the procedure. If we are planning for a monovision in some cases, explain to the patient what the concept is. Give a contact lens trial for 1 week to see if the patient adjusts to monovision. Not all patients adjust to this procedure, so always give a trial before proceeding. And always tell the patient that there may be cases where there may be a loss of depth perception. So if there's a patient who needs this because of his profession, do not go ahead with such a procedure. There are many patients who will come at the cusp of 18. They want to get refractive surgery done because of a job enrollment. They have to get in. In these patients, it's very important to explain that if there is not a stable refraction and you are going ahead with the procedure, that there may be regression due to unstable refraction. If in case patient is not willing for getting a ICL or an IPCL procedure done in extremely high myopia, and they insist on getting a keratorefractive procedure done, you may have to leave behind some amount of residual error because you have to play within the limits. And there is a possibility that the entire number cannot be corrected. In hyperopes, sometimes you do an overcorrection to prevent the manifestation of latent hyperopia and to compensate for some degrees of regression. Smaller optical zones are sometimes done to save on tissue ablation, which may lead to glares, halos, and difficulty in night driving. This should be conveyed to the patient pre-hand itself. And lastly, always take a consent of everything in the patient's language and so in English and in the patient's language before proceeding with any procedure. Thank you.
Thank you everyone for having attended the session. Because of paucity of time, we can't take questions. But then, because we have to hand over the the auditorium to the next session, which is starting immediately. But in case there are any questions, I'm sure all our instructors are available and we can have a 1:1 chat outside this hall immediately.